What was about the APHINITY trial? In this presentation, you looked at the cardiac safety of dual blockade with Pertuzumab and Trastuzumab. We know that this combination improves the patient's outcome in early breast cancer and is now recommended for patients with early breast cancer to positive and a high risk of a recurrence. But we also know that anti-HER2 drugs may increase the cardiac toxicity compared to no anti-HER2 drugs. So we looked into the database of APHINITY with a follow-up of 74 months, which is a long follow-up. These patients in APHINITY are going to be followed up to 10 years. So APHINITY was a randomized phase 3 trial looking to patients with HER2 positive disease, early breast cancer. Those patients were randomized to receive chemotherapy, Pertuzumab, Trastuzumab, or chemotherapy, Trastuzumab placebo. Nearly 5,000 patients entered into the trial. How you define the cardiac events in our trial? So we defined the primary cardiac events, which was congestive heart failure class 3 and 4, or cardiac death. The secondary cardiac events, asymptomatic or mild symptomatic, significant LVEF decline. And you also define acute recovery, that was patient experiencing a cardiac event. They had to have at least 2 LVEF assessments greater or equal than 50% after the cardiac event. We looked in our patient population, is well balanced between the two treatment groups, so there is no major concern, no imbalance, but you can see that anthracycline chemotherapy was mostly used in both treatment arms. So 77% of the patients, they still receive an anthracycline-based chemotherapy, which you know that can increase the risk of cardiotoxicity. But the cumulative dose of either doxorubicin or epirubicin was similar in both treatment arms. So we also looked into whether patients had to discontinue treatment due to cardiac safety. And this is very low in both treatment arms, about 3.3 and 3.5%. And if you look now in terms of cardiac events, if you look at the dual blockade with Pertuzumab, Trastuzumab, we have few cardiac events. 2.7% of patients experience a secondary cardiac event, and in the Trastuzumab placebo arm, 2.8%. So there is an increase in cardiac toxicity with the dual blockade. If you look in terms of congestive heart failure, class 3 and 4, the more severe ones, this was less than 1% in both treatment arms, so it's quite reassuring. But we also look in terms of chemotherapy anthracycline and non-anthracycline. Since the majority of patients had an anthracycline-based chemotherapy, we can see slightly more cardiac events in the anthracycline group. 3.1% for secondary cardiac events compared to 1.6% in the non-anthracycline chemotherapy regimen. So this calls our attention that when you are prescribing a chemotherapy and you need to give anti-HER2 drugs to your patients, you really need to have very extensive cardiac risk assessment, and you have to tailor the chemotherapy according to cardiac risk. But what was good news, we looked into when those cardiac events occur, and you can see that most of those cardiac events, they did occur during the treatment phase. Very few cardiac events occur after the treatment has been completed, and the median time to develop a first cardiac event was 8.4 months. What is good news for the patients is when they develop, for instance, a secondary cardiac event, we can see that 86% of those patients, they do recover from the cardiac event. So they need to be seen by a cardiologist, they need to sometimes treat with pharmacotropics, and they do recover for this. So it's not an irreversible thing. And the median time to recover is about 23 weeks. And if you look in terms of how was the LVEF values in both treatment arms, Pertuzumab, Trastuzumab, or Trastuzumab placebo, across the whole treatment, the whole trial duration that is now 74 months, you can see there is no major concern with dual blockade. The dual blockade does not increase the risk of cardiotoxicity. And you also want to know which are the type of patients, who are the type of patients that can develop a cardiac event. So you look for specific cardiac events, and in multivariate analysis, you could find that those patients with age 65 or older, they have more chance to develop a cardiac event. Those obese patients that start treatment, they have a LVF between 55 and 60%, and also patients who are treated with an anthracycline-based chemotherapy. So those patients, we really need to assess them before starting treatment from a cardiac point of view. Should I give anthracycline-based chemotherapy with anti-HER2, or should I give a non-anthracycline-based chemotherapy? So this is important to tailor the treatment of your patient. So what can you conclude from this data that I showed in the APHINITY? We can say that with almost 6 years, we can confirm that dual blockade with Pertuzumab and Trastuzumab is safe. There is not an increase of cardiac toxicity with dual blockade. We can also show that most of the cardiac events, they occur during the treatment, and they are the low grade, and there is a low incidence. Another thing that is important is that it is reversible in the majority of the cases. Like secondary cardiac event, 86% are reversible. And of course, anthracycline can increase the risk, so this should be particularly taken into account when you decide the chemotherapy. Another thing that we cannot forget, you have to continue assessing cardiac safety during the treatment and sometimes after the treatment. But one important point here that I stress about the cardiac risk and assessing patient safety before start chemotherapy is that patients in general that are included in clinical trials, they tend to be healthier. They have less disease, they are younger. So this we really need to be careful in a day-to-day practice. When you have older patients with multiple disease, you really need to assess this patient from a cardiac point of view and ensure that the patient is followed during the anti-HER2 treatment. With this, I would like to thank you for your attention.